Oh, you can see really good like that.
Okay. When do you all have your ATI for maternity?
Yes.
We really don't.
Okay, we have.
This is what I have. I have like CC maternity.
Okay. We have we can do like today or Friday or next week. One for nutrition and one for farm.
Yeah, we don't do
It's
like
Proctor.
a weekly thing like we do with management care.
It is
Do you
Proctor,
have, like,
but that's
a-
nutrition and farm.
Do you have like a set date that you have to take an ATI on maternity?
I think so.
Yes.
Yes.
Is it towards the end of the
Yes.
semester?
That's how
Yes.
April.
Mm-hmm.
Okay.
Because we
Well,
already
you all
took-
will be set to go for that because, you know, you've been, if you go through these practice to help you prep for the test, you will have gotten used to kind of ATI's type of questions and will probably do better on the maternity if you do these practice. All right. So let's open, we're going to do the one on labor.
All right.
And we'll do the same type. So when I do these with my students, I do not know the answers to these. I can only just do the best that I can, and then we kind of talk through them. The students like it like that, so. Okay, y'all ready? Is this kind of hard to see? Can I zoom in?
I can see that.
You're so little.
I don't know if I can zoom in or not. Oh, snap. What did I do? I don't think I can zoom in. I'm sorry. Well, I'll read it out loud. A nurse in labor and delivery is caring for a client. Following the delivery of the placenta, the nurse examines the umbilical cord. Which of the following vessels should the nurse expect to observe in the umbilical cord? A, 2 veins and 1 artery. B, 1 artery and 1 vein. C, 2 arteries and 1 vein. Or D, 2 arteries and 2 veins.
See.
Hold up your card.
Oh,
Do
wait.
you all still have your card?
What is it?
It is C.
Mhm.
It's ABA.
Mhm.
That's how you remember it.
Yes.
Oh.
Yeah, it's
So it's 2 arteries. One. I got it backwards.
yeah, ABA.
Yes.
That's how you remember the umbilical cord. Follow along.
That's what I remember.
Yep. And it's actually opposite. So if you all get some type of question on this, the vein carried on. So the vein carries the oxygenated, nutrient-rich blood from the placenta to the fetus. So the vein is actually what supplies the fetus with its nutrients and oxygen.
Respiration is
The
backward. from the mom.
arteries return the blood to the placenta. That is mixed, that is backed up. That's opposite from us, right? Because our arteries provide our tissues with blood and nutrients, and our veins carry it back to our heart. But with the baby, it's the veins that actually carry. And I got that wrong in a test once, so that's why I'll always remember it. I'll never forget that one. Okay.
Oh,
Yeah.
You know the maternity practice too, right?
Yes.
Okay, this is my first question.
So it does. Anytime you go in, the order of it will be separate from mine. Yeah. And so we just have to sit and talk through them, like on the projection. And I wish I could make it bigger, but I can't. A nurse is caring for a client who experienced a cesarean birth due to dysfunctional labor. The client states that she is disappointed that she did not have the natural childbirth. Which of the following responses should the nurse make? A, it sounds like you are feeling sad that things didn't go as planned. B, at least you know you have a healthy baby. C, maybe next time you can have a vaginal delivery. Or D, you can resume sexual relations sooner than if you had a vaginal delivery. That is like a,
That's like a.
But we have to pick up therapeutic
that's
communication,
like
right?
The patient anything to say back, really. Right?
yeah.
It's just
So
kind of.
which response would you feel like would be most therapeutic?
I guess baby.
I don't know. I guess A maybe.
Like it seems like you feel like so you can just like
At
open
least
more.
you know you have a healthy baby. Yeah.
No, that's the kind of man. I'm like,
What do you all
So-
think? So I got 2 days over here.
Yeah.
I just think like it seems like so it's like an open conversation, so you can tell
Yeah.
more about
You think
it.
that it's more open-ended. She
Mhm.
might more so express her emotions with if you say one. What do you all feel like? One? That's okay. I think that it's A.
Okay.
I think that it's A because it sounds like you were feeling sad that things didn't go as planned. This is a very therapeutic response in that I am validating her feelings. So I'm saying, oh, it seems like you might be sad that things didn't go as you planned. And this is more of a response that if I say this to her, she might say, well, yeah, I am really upset because of X, Y, and Z. Like, I really wanted to have a vaginal birth because I didn't want a scar when I go to the beach or, whatever. B is very blatantly wrong. You should never tell a mom that at least you know you have a healthy baby. That is like a very, it can be very hurtful for moms because, yes, it is important that she has a healthy baby, but what about her? Her body was just almost ripped in two to get this baby out. And some moms will have very traumatic and birth experiences. And so you never say to a mom who might have a traumatic birth experience, well, look, you have a healthy baby. That's all that matters, right? No, her emotions, her trauma, what she's been through matters. Maybe next time you can have a vaginal delivery. This is blatantly wrong too because she had a dysfunctional labor and she had a cesarean birth. Sometimes after cesarean births, you may not be a candidate for a VBAC. Have you all heard about VBACs? VBACs were very controversial when I was in nursing school because of supposedly the risk of uterine rupture. Have you all heard? Are you all familiar with that? Well, nowadays, they have done research and it shows that really the risk for uterine rupture is very minimal. So a lot of moms are doing VBACs. And at University of Louisville Hospital, where they have midwives, well, actually over at Clark Memorial, they have like a 99% success rate with VBACs over across the river. So like VBACs are happening, but you have to be a candidate. So you might not know, she may not be able to have, it depends on, she might not be able to have a vaginal delivery. And this, you can resume sexual relations sooner than if you had a vaginal. Absolutely not. It's 6 weeks. You cannot have sex. And the rationale behind that is because that placenta has come off your wall now. Now the baby's out. And if I insert a penis into my vagina, because my cervix stays open for quite some time. So now my cervix is open. I have this sore area. It's an open area on my uterus. And if I insert a penis into my vagina and now I've got a straight path of infection straight into my blood, that right there is how women end up with uterine infections post-birth. Because their husbands will push them to have sex. And sometimes the moms want to too. I mean, it's not just the husband, but sometimes, because hormones are all over the place. And so you have to really educate on why they need to. Yay, it's correct. And it says this is not therapeutic either, this last one, because it's unrelated to the topic. But that's really not true either. Like, that's wrong. You might want to give your patient false information. A nurse on the labor and delivery unit is caring for a client who is having a difficult, prolonged labor with severe backache. That sounds like my 72-hour labor. Which of the following contributing causes should the nurse identify? So, which one of these could contribute to her prolonged severe back pain labor? So 1, fetal attitude and general flexion. What does that even mean? Is that like the fetal position? Fetal attitude?
I looked it up.
Really?
Okay.
I didn't need. For me, it looks like the fetus is bad. Or
I
it's,
know. Fetal
like,
attitude.
it's
I can see
mad
how
or
that
something.
would throw off an ESL student. Like, like what? The baby's mad?
I'm like,
What? Yeah. I think it's actually their position. Isn't that right?
Yes, I think
it
so.
fetal
I was
attitude
looking-
means
'cause I wrote
position?
down something.
Okay, but they're in a general flexion, which we want them to be, right? Flex. Fetal lie is longitudinal. This is a hard question, you all. Do we want them to be longitudinal? No. So that
One
could,
encephalic.
yeah, no, we wouldn't want. So I would throw out A, and I'm going to keep B. C, maternal pelvis is gynecoid.
Mhm.
I think gynecoid is actually favorable for birth. It's flat and android that are bad. Is that sounding familiar about your pelvis shapes? No, flat can be bad and android can be bad. Am I thinking about android as I don't know. D, fetal position is persistent occipital posterior.
Let's look it up.
OP.
It's
Oh,
looking
OP.
backwards, so it's gonna
So
push
is he
the.
looking backwards or he's not looking backwards? His occiput,
Uh-huh.
occiput's the back of the head, is posterior to mom. Does that make sense? So his back of the head is on her
Coccyx?
tailbone.
So where's the eyes then?
The eyes are looking forward.
Over here.
Okay, that's
To
kind of
this
what I
side.
meant.
Is that how you want baby to come out? How do you want baby to come out?
Yeah,
What's the optimal?
it's called
LOA, but I don't remember
It's
what.
OA.
OA.
But I don't know what it
Occiput
means.
anterior.
Oh, okay.
We want baby to come out occiput anterior. So
I'm gonna go with D.
So what do you all feel like is the right answer? D?
Mhm.
I'm pretty sure it's D. And you know, I know this because of all my doula work. Anytime we've got an OP baby, we will have terrible back pain.
Oh,
Where you get back labor because baby is OP. You want baby to be OA. The longitudinal lie, so let's say I threw out B or A and C, and I was between the longitudinal lie versus the OP. The back pain is really what gets at me to say that D is probably the right answer. Yeah, because of the back pain. If you have a mom and baby is OP and you're having a lot of back pain, put them on their hands and knees. They say that that's the most beneficial way to get baby to rotate.
Like
Because-
rapidity.
Huh? Yeah, like a dog or something, like hands and knees. Yeah. That's right. So the longitudinal fetal lie is the most common position for vaginal birth and is not contributing cause of back pain. I thought I guess I was thinking lateral. So I guess a longitudinal lie is good. Yeah. Why was I thinking longitudinal like?
Like a horse, like
Yeah, I was thinking horizontal.
Mhm.
But then a gynecoid maternal pelvis is the most common type and is not a contributing factor for back pain. But the OP is bad. It's bad for back pain. And look, it even tells you, look, counter pressure or a hands and knees position can offer pain relief. So you actually do counter pressure on her sacrum with the heel of your hand. You just kind of push on her sacrum. And the benefit of that is when you push on the sacrum, it kind of gives the pelvis a little bit more flexibility and kind of opens it up. And baby a lot of times can flip around if you will do, and it helps with pain and everything like that, the counter pressure does. All right, number 4. A nurse is caring for a client who is in the active phase of the first stage of labor. These stages of labor and finding out like how your mom's going to act in these stages is going to be really big on this next test. Anytime you've got a test on labor and labor and delivery, you have to know Well, it's not technically active labor until you're like, I don't know what they're teaching you all now, 5 to 7 centimeters dilated.
Usually 7 to 10.
What?
To
I didn't
10.
hear your question.
So active labor,
It's
So-
4 to 7.
4 to 7.
Oh, that's
Pre-
second phase because first stage is 0 to 3, and then 4
Uh-huh.
to 7 is second stage, and third stage is
Delivery of the placenta.
But
Or the
early
phase. I'm
sorry,
phase
phase.
active is 4 to
Okay.
7.
There's
First is-
Transition
okay.
8 to 10.
let me just don't confuse. Like we talk about that today. It's like first stage has 3 phases. First phase is until 3 centimeters.
Uh-huh. 0 to
Second
3.
phase is 4 to 7, and the last phase
So they're
is
saying-
7.
So they're
to 10.
saying active labor
It's the second.
doesn't truly, so transition is
Third.
7 to 9. So
I wrote
there's
8 to 10, but
there's preterm, or there's not preterm, it's prodromal or false labor, right? Y'all heard about this? Prodromal labor? What are your, so there's how many stages of?
There's 3 stages,
Yeah,
and then I think the first stage has like 3 phases to it.
That's-
is
yes.
what she's trying to say.
yeah,
Mhm.
what are the phases of labor?
Uh,
You should have
early-
active, transition, pushing.
we say early or latent.
Yes,
then
early or
active,
late
and then
is the 0
transition.
to 3.
Yes.
A lot of times they will not admit you unless you're 3 centimeters. But knowing what all of those kind of look like and what your mom is going to act like, what are her contractions going to look like in early or latent phase?
Right.
It's going to be like the contractions might be like 7 minutes apart, 5 to 7 minutes apart. They might be 30 seconds to a minute. They're not going to be very, so knowing what your contractions look like, how far spaced apart they are in each phase. And also, a mom in early labor, they're fine. Okay, they can handle the contractions. When they start getting into that active labor, like 4 or 5, they start saying, ooh, they have to concentrate on getting through, and they may tell you to like be quiet. Transition is 7 to like 9, I think. It's 7 to 9. When they're in transition, that mom is going through hell, especially if she is non-medicated. If she does not have an epidural, she hates you. The only thing she might want you to do, she's not going to want you to massage her or talk to her or anything like that. She's going to want some counter pressure, and that's all she's going to want. And then the last phase, obviously, is pushing. So that's when baby starts to come down. And yeah, you're right. So there's stages, and then there's phases within the stages. Know those for your test, because that's a critical point for you to identify. Because I'll tell you what the question, I'm not your teacher, so I don't know, but the questions that I've seen are, they will say, your mom is acting like this, she's walking around, she's pacing through the halls, your contractions are so many minutes apart. What phase of labor would you expect her to be in? You see what I'm saying? So being aware, that's how your questions might be worded. And knowing those phases is very important in knowing your interventions, what you should be doing. So she's in the active phase of labor. So we know with active, she's like probably like what, 5 to 7, somewhere in there. She may be anywhere between like 4 and 7. Yeah. Once you get to that 7 though, you're in transition. Yeah. You start transitioning and things start to get real bad right there. So when monitoring the uterine contractions, which of the following findings should the nurse report to the provider? A, contractions lasting longer than 90 minutes or 90 seconds. Oh my God, 90 minutes, you're dead. B, contractions occurring every 3 to 5 minutes. D or C, contractions are strong in intensity. Or D, client reports feeling contractions in the lower back. So what would we need to report?
I think it was 3 contractions.
forgot the question.
Okay. You don't understand the question?
No, I just forgot the question. Like I just
Oh,
stopped on faces and I just forgot whatever it was coming from.
okay, so this
Sorry.
client is in active labor and we're monitoring uterine contractions. Which of the findings here should we report to the provider?
Okay.
Oh, report?
Yeah, which of the findings should we report, not expect to find?
See, I wasn't listening.
Yeah, it's okay. So we need to report either, so contractions lasting longer than second minute or 90 seconds. B, contractions occurring every 3 to 5 minutes. C, contractions are strong in intensity. D, client reports feeling contractions in lower back. So Jasmine, I've got your answers locked in. And this is why you need to know your phases of labor, right? But I did tell you all this
I'm gonna
earlier in the first session.
You noticed
I
that
said this.
one.
Yep. Jasmine must have been listening. She listened to me because I was her clinical instructor. She's used to hearing my voice, right?
Damn, contractions. Greater than
Yes.
90 seconds. We're already
Yes.
done.
It's
Oh,
A.
that's
If,
right.
if the contractions last longer than 90 seconds, you've got a problem. You've got possibility for fetal distress. Didn't we talk about that on this thing? Did we talk about that yet?
Oh,
Yeah,
you
we
said.
assessed.
We sure did.
Oh my
Yeah,
goodness.
I
got
Oh,
it.
you say last longer than, no less than 90 seconds.
They last.
Longer.
Yeah. Lasting longer.
Okay. My
So
bad.
A.
I thought I said less than
So
90
this,
seconds. I was like,
this active phase of labor, contractions normally do go to from 3 to 5 minutes. So that's
That was my
normal
first.
for active labor. Yeah. But anytime you see 90 seconds or longer, or if they're closer than a minute apart, you better be calling somebody.
Mhm.
And you better be figuring out what you're going to do because baby's not going to be able to tolerate that very long. Yeah. All right. A nurse is creating the plan of care for a client who is at 39 weeks of gestation and in active labor. Which of the following actions should the nurse include in the plan of care? So which one should we do for a patient that is 39 weeks and she's in active labor? A, keep 4 side rails up while the client is in bed. B, check the cervix prior to analgesic administration. C, monitor the fetal heart rate every hour. Or D, insert an indwelling urinary catheter. This one's a little interesting.
It is, isn't it?
This is like a classic ATI. Is this not? This is a classic
Yes.
ATI question right here.
So, nurse's care. She's in active labor, so. Which is 4 seconds.
And to be quite honest, I'm not sure about this one.
I'm like, we're going to be checking continuously her rate.
Yeah,
Yeah.
heart rate's
So
like
it's like
continuous.
that one is
We
not.
can throw that. So
We throw
what
that one.
Unette just said is we can
I'm
probably
gonna
throw C out
go with,
I-
I'm gonna go with,
because we
And-
need to be monitoring continuous.
And why
Yeah.
a catheter? We don't need a catheter.
Yeah.
I'm
And
going
catheter,
with-
yeah, catheter can
we
go
don't,
out.
we
So
don't
we
put
can-
all 4 rails
It is
up,
restricted.
right?
And we don't do
So I'm
restraints.
gonna
Unless
to go
she's preeclamptic and she's going to have
Yeah,
seizures.
you.
We
Okay,
won't do
so
that.
You all are gonna do B.
I think so.
Okay, I think B. I think that's a good check the cervix prior to analgesic administration. I would personally prefer, as a patient, to have analgesia before you stick your fingers in me and I'm in active labor.
Right. Because active's already between the 4 and the 7, right?
Yeah, but how are
it's-
you going to check?
She's an
like,
active. I mean,
how
she's
much?
hurting. Like these contractions, she's feeling them.
She's feeling them.
Yeah. Let's just go with it. Let's see what ATI says. And it's correct. Yay! Good job, everyone. So prior to administering analgesic during active labor, the nurse must know how many centimeters the cervix is dilated. Administration too close to the time of delivery could cause, I knew this, could cause respiratory depression in the newborn, especially if you give some type of opioid or morphine. Yeah. That right there is a good question, isn't it? That's a good
Yeah.
question. I like that. And I will tell you, I didn't say this before we answered it, but when I was in labor, and you know how I had precipitous birth, and I was 10 centimeters when I walked in. I mean, I was completely dilated. And that nurse, when she checked my cervix, and I was completely dilated, and I was probably in transition because I think I was just completely, open. I was getting ready to push. I went all natural too, but there was no analgesic. She was ready to check me as soon as I came in that door. And let me tell you, she about got kicked because she was like, I need to check you through a contraction, supposedly. She's like, I need to check you to see if the head's coming down. She about got kicked. And I actually really like that nurse. We were really close, and I was like, you do understand that I about kicked you, though. She's like, yeah, it's okay. Don't be an L&D nurse unless you're not afraid of being kicked, stabbed, hit.
Bite.
Yeah. Okay, a nurse is caring for a client who is in active labor with 7 centimeters of cervical dilation and 100% effacement. Ooh, she's getting ready, and she's
Ready.
The fetus is at a 1+ station. What does this mean?
1+. I like this.
You
It's
all,
like
this, I'm
life
telling you, I think this
5
next test
plus.
is going to be extreme.
1+.
Because the test on labor and deliveries, that's a lot of content.
Right
It's
here.
kind of hard. When is your all's next exam?
Right here.
A week before spring break.
Yeah.
In 2 weeks.
Okay,
March
so
5th.
okay. You've got a little bit.
It's just
So 1+ means baby's head is below the ischial spines, right? Ischial spines, I think that's what
Right here.
they
Yeah.
landmark that as. If it's
So-
-1,
And it's
yeah, so baby's head is coming out, like it's down, it's engaged is what that means. It's not coming out of her cervix, right? Because she's still closed, she's not all the way open. But baby's head is down, engaged, ready to possibly start coming. And the client's amniotic membranes are intact, which is a good thing because we don't want these amniotic fluid membranes broken for too long. Because if they're broken for too long, what's the risk there?
infection.
Absolutely, infection. And whenever you hear a labor and delivery nurse pass off communication, they always say the time that the membranes ruptured.
Yeah.
Yeah, they always include that in their report. The client suddenly states that she needs to push. Which of the following actions should the nurse take? A, assist the client into a comfortable position. B, observe the perineum for signs of crowning. C, have the client pant during the next contractions. Or D, help the client to the bathroom to void. These questions are not easy, you all.
No, but we don't want her to push because she's 7 centimeters, right?
and we don't
That's why
want
I said these questions are.
we don't want them to
Okay,
walk.
But
what I'm
here's the
thinking.
thing. It is possible. If a mom tells me that she needs to push,
Maybe
like
it's
she
split on
she
me.
probably needs to push.
Okay.
But if she's only 7 centimeters and I just checked that, now it's possible for them just to go bloop and open right back, right up. Go from 7 to 10, like that happens all the time. If she's telling me that she needs to push, what? Okay, let's just say, so for A, assist the client into a comfortable position. That might be a good option,
Less
Because-
invasive.
huh?
It is less
It is
invasive.
less invasive, you're right. Okay, so I'm going to keep that one.
So,
Observe the perineum for signs of crowning.
so
I mean,
would you just look at the?
Yeah, you would just look at her, look in her vagina and see if you see a bulge coming. And once you see a baby come out of a vagina, you will never forget what it looks like. I promise you that, ever in your entire life. Yeah. See? Have the client pant during the next contractions. Do you all feel like we could throw that one out?
Throw that out.
Yeah. D, help the client to the bathroom to void. I feel like that's kind of a good option too, but I don't want baby to fall into the toilet.
She's saying
Dr.
she
Turner
thinks
just tell
she
us that today,
could.
like when she's in 7 to 10,
Yeah.
we want them back to bed because
Yeah,
after a
'cause
really
baby's
good
gonna come out.
contraction, and the mom can fall. Like
Yeah.
we don't know how strong those
I think we
contractions
need
are
to-
becoming.
I think we need to throw D out. I'm between A and B. And if somebody's telling me that they need to push, I'm gonna look down there.
Oh yeah, that's what I was thinking.
Real life.
Real life.
Because this A makes me feel like I'm just gonna help her into a comfortable position, be like, peace, bye.
Yeah.
No, if you're telling me like you need to
Let me
push,
look and see what's coming.
yeah, I need to see and look at your perineum. I'm gonna go with B, but I
It's
feel
either
like
that or the
A.
bathroom.
I feel like A is less invasive, but I don't know. I feel like B is just pulling me, especially since she's 100% effaced.
Mm-hmm.
That's incorrect.
What? See?
So
What was
at 7 centimeters dilation, it's too soon to observe for crowning.
oh,
See, this is me and my doula experience that can get in the way. You know, I've seen moms, they can go from 7 to 10 in a hot minute. Like they can.
panting and rep. You want
So-
them to pant. Okay.
See, so supposedly panting is rapid continuous shallow breathing. It helps the client in labor from pushing because her cervix reaches before her cervix reaches full dilation. Observe for hyperventilation and have the client exhale slowly through pursed lips. So you will hear this sometimes that they have a cervical lip. And that means like the cervix is not dilated all the way and there's a little bit of the cervix still left in front of the baby's head. And if you have a cervical lip, they do tell you to try to breathe and not push. Because what happens, and I should have just taken this with and do you all see how I thought into this? It says that she was 7 centimeters. But I was like, well, she could have been 7 centimeters like a couple minutes ago and now she's 10, you know? So try your best. I mean, I personally just did. I just thought way too far into it. So take it at face value with what they give you.
Why there is no A correct?
A comfortable position will not affect the client's need to push.
She'll still want to push.
Emptying the bladder does not alter the client's urge to push. Supposedly breathing does. Next question. I'm kind of over that question. A nurse is caring for a client who is in active labor and notes late decelerations in the fetal heart rate. Look, guys, which of the following actions should the nurse take? A, apply a fetal scalp electrode. That's what we were trying to talk. That's what we were just
That's what
trying
it
to
is.
say.
That's what it's called.
Yeah. B, increase the rate of IV infusion. C, administer oxygen at 10 liters via a non-rebreather mask. Or D, change the client's position. Good little ATI. I'm telling you, this one. Okay, so
Notes late.
we've got late decelerations, which we talked about fetal distress, remember? Late is bad, right? Always bad if you're late. Which of the following actions should the nurse take first? So apply a fetal scalp electrode. That's not going to be my first intervention, is it? You may do that, but honestly, if they're in distress, you need to be doing some other stuff first. So A is out. Increase IV infusion, out. So we're in between C and D. And I will tell you this, if baby's heart rate is in distress, the very first thing is I would throw her on her left side and then apply oxygen.
So no ABCs in here?
With labor and delivery, almost always you want to throw her on her left side first and then apply oxygen. So I'm thinking, a lot of you all were between C and D and you picked C. I'm thinking that it's change the client's position. Even though it doesn't say specifically lateral, I think D. And it's correct.
Yeah.
which is just the same as if you had somebody in respiratory distress, you change their position very first before you apply oxygen because it's fast. Supposedly, that's a faster fix. You may not have a non-rebreather sitting at your bedside.
What can I do right now?
Yeah, the
Yeah.
position change is the very first thing. A lot of times, if you're in between choosing those two things, I go with the position change. And the first action, so it's an attempt to increase blood flow to the uterus or to the fetus. Oh, select all and apply. Great.
Love it.
And pharmacology, all in one.
We're lucky.
A nurse is admitting a client who has a diagnosis of preterm labor. The nurse anticipates a prescription by the provider for which of the following medications? Select all that apply. Prostaglandin E. That's A. B. Indomethacin. C. Magnesium sulfate. 3. Methergonavin. D. And then E. Oxytocin. Let's just throw some out. Do you think they're going to give prostaglandin for a preterm labor?
I don't think so.
My understanding from prostaglandins is they cause inflammation. They cause like a little bit of inflammation. It's like a chemical that's sent off through inflammation. And you know what they tell you? You know why having sex before like going into labor is a thing? It's because semen has prostaglandins in it. It gets on your cervix and it helps kind of induce labor, supposedly. Yeah, so that's why moms will actually try to have sex if they have gone past their due date, they're overdue, and that's the thought. So obviously, if they're in preterm labor, I don't think we're going to give prostaglandin. I don't know what this indomethacin
I don't
is.
either.
Yeah.
I'm thinking it's some type of steroid though, but it doesn't end in SONE, which is like a steroid. You know what steroids end in? I'm for sure about mag sulfate. I'm not sure about this methogonavin. I know Methergin you give when you are at risk for bleeding. So I don't know if those are similar. I'm going to throw this out. I don't like it. I don't know why I don't like it. Oxytocin, obviously not. I'm going to hit B and C. And just see what that is.
Whenever it's a B, is a non-steroidal anti-inflammatory drug. It's used to reduce swelling, to treat pain.
Okay. So it's not a steroid?
It's a non-steroid anti-inflammatory
I
drug.
wonder what this is. I'm sure the rationale will tell us. Let's just go from there.
Anti-inflammatory.
Guys, I got it correct. Look at my test-taking technique. I did not know that one. Did not know that.
Mm-hmm.
So supposedly, prostaglandin is used to stimulate cervical ripening, like I told you all, right? And hasten the onset of labor. So no to that. Indomethacin is correct. It's used to relax uterine muscles and suppress uterine activity. Magnesium sulfate is correct. It's a tocolytic. How you say that? Tocolytic and stops contractions in clients experiencing preterm labor. Methergonavin, it promotes uterine contractions to manage. Didn't I tell you all Methergin? I think that is Methergin. Because I said that helps with bleeding after. I think that's IM because I think I had a doula client get that once because she was bleeding out. She had twins.
Ooh.
And when you have twins, that's 2 placentas that you're bleeding for. And they took her babies away from her. Yeah. I said, give me those babies back. They need to be on the boob. Because what do we know about breastfeeding?
Release oxytocin.
It releases oxytocin and helps with contractions and it helps prevent bleeding. So really, bringing baby to the breast will help with postpartum hemorrhage, help reduce the risk of it. Oxytocin is incorrect because it is used to induce labor. Okay, y'all want to do one more and then let's get out of here?
Yes.
Okay. A nurse is completing discharge teaching to a client who is in her 35th week of pregnancy who has mild preeclampsia. These questions are good. These are all stuff that we've talked about, aren't they? Which of the following information about nutrition should be included in the teaching? A, consume 40 to 50 grams of protein daily. B, avoid salting of foods during cooking. C, drink 48 to 64 ounces of water daily. D, limit intake of whole grains, raw fruits, and vegetables. Let's throw some stuff out. 40 to 50 grams of protein. That seems like a lot to me. Are we really worried about protein with
No, we're not.
preeclampsia?
Throw it out.
Throw that out. Salt. Are we worried about salt with preeclampsia? What's the big deal with preeclampsia? Like, what is the cause of preeclampsia?
Increase blood
Basically,
pressure.
constriction.
Hypertension and blood
Hypertension.
pressure.
Which causes the constriction.
Absolutely. It's gestational hypertension that leads into preeclampsia, right? Remember how we talked about that? Like, preeclampsia is a complication of gestational hypertension.
Mhm.
So, absolutely, B, it looks good. Drink 48 to 64 fluid ounces of water daily. I almost think you should drink more than that. Like, 48 is not even enough. But then you also don't want to drink too much because, yeah, I don't like that answer. I throw that out. I'm curious what the rationale is going to be. Limit intake of whole grains, raw fruits, and vegetables. No. I think these is a solid answer. And look, it's wrong.
What is it? What is it?
The water?
The water?
Okay, so let's talk why A is wrong. So the client who has mild preeclampsia is encouraged to consume 60 to 70 grams of protein, 120 milligrams of calcium, folic acid, zinc, and sodium in her daily diet. Protein is needed for tissue and integrity and calories. So avoid salting of foods during cooking. The client who has preeclampsia is instructed to salt foods to taste and limit consumption of foods that are high in sodium, such as chips. I don't like that. I feel like here it says you should limit consumption of foods that are high in sodium.
But salt your food.
Salt your food. That's the first
I
time.
don't
that
like this answer. Let's see why they think C is correct. The client who has preeclampsia is encouraged to drink 6 to 8 fluid ounces of water. So that is 48 to 64. I always encourage people to take more than 64. That 48 kind of was like, per day. She should avoid alcohol and limit intake of caffeinated beverages. I guess it's correct, but still, I don't like that very well because she shouldn't be adding a whole bunch of extra salt. No. And so she should, with the whole grain, she should have an additional fiber that comes from whole grains. You know, ATI sometimes will throw those out, ones that I'm like, I don't really know about that, but yeah. It at least sparks good conversation. All right, do you all have any questions for me?